Hi, I'm Dr. Kraekel. I'm one of the orthopedic surgeons at OrthoVirginia. I'm at our Springfield and Alexandria offices, and today I specialize. I'm board certified and fellowship trained in adult hip and knee reconstruction or joint replacement and the revisions of those procedures. I do everything from partial knees to complex revisions, and today I thought it'd be interesting a lot to talk about some of the advanced technologies that are available to us in total joint replacement. I think there'll be a lot of opportunity for discussion and questions, because I think this is one of these topics that it's just more dispelling some of the things that are out there, curiosities. I'm sure it'll be good to just have a conversation. So I'll give a little overview, but then I'm looking forward to fielding some questions. Basically, for both hip and knee replacement, we have a development of, really in the last 15, but really the last 5 to 10 years, technology's really taken a real jump into what we do on a day-to-day basis. People have heard about robotic surgery for a lot of general surgery procedures, and robotics really entered the realm when we started doing them for partial knee replacements initially. There was a system that came out about 15 years ago where it was CT-based, Mako, and being able to do, they were an independent company for doing it for partial knees. That's been since acquired by another company, and they've really expanded what that's available for in terms of doing total knees and total hips, and future for doing revisions and things like that too. And with that, as that boom has happened, most of the companies on the market have also sort of stayed in line and created their own individual similarities in terms of robotics. What I hope to make people understand is, the robotic stuff or the robotic equipment that we use is different than what people often are using in general surgery or Da Vinci. So when hospitals talk about a robot, sometimes they're referring to that more general surgery, urology type robot. The ones that are utilized in orthopedics are different, but really for the market that has grown exponentially over the last 5 years. What I think would be worth understanding is when we're doing a surgery, there's the traditional way that we do a knee replacement, for example. We would have to make sure that we cut a straight line. Just as an example, this is a knee replacement. If we wanted to put a metal implant onto it, we had to make geometric cuts that are very precise for that implant to fit onto it. To do that, it takes having traditionally, instead of just looking at it like a carpenter and saying, yeah, that looks good, most of you would want us to have a little more precision to that. And so we utilized some jigs or instruments that would allow us in a traditional knee replacement to more or less, we could put a line or a metal rod, frankly, down the middle of the implant of the bone. Basically this metal piece would go down the center of the bone, and we would be able to cut a very precise angle relative to that. So we may want it to be at 5 degrees to make it similar to the actual axis at which your leg is normally aligned, and we might change that based on the patient's height or something like that. What we now can do is we actually have gone into getting full-length x-rays where we can get full-length films from someone's hip to their ankle and really know exactly what angle that should be. That was probably some of the earlier versions of sort of it incorporating technology. And then we started utilizing things like CAT scans to know, we don't just need to know the alignment, but exactly the three-dimensional topography of the bone. And some of the things we did were more for navigation, where we can put some pins into the bone. And if you look at any video about robotics, you can see this, but we would put two pins sort of in the tibia, 2 in the femur, and that will have an array that has basically some imaging, and it's a camera that will actually interact and read where that bone is relative in space. So if you can calibrate the positioning of the limb when you bend the knee or move it, it knows where the tibia is and where the femur is, and therefore in the relationship between those two. And so there's ways that we can intraoperatively map out that implant, and there are different companies out there which would be doing more of this navigation type way of measuring where your implant is in space. There's other technologies where that navigation is then paired with a robotic arm that will not only know where the implant is in space, but it would allow us to make those very precise cuts that I talked about in a very precise way relative to where the leg is. So if the leg moves during surgery, that robotic arm would move with it. And there's I have had a hand in developing several robotic programs at hospitals. So I was in a previous practice out of state in Houston. I built a program there for robotic knees and hips, and we were doing a lot of robotic joint replacement. And then I introduced it at that facility, and then we started doing it again here, and I've recently introduced it to one of the main hospitals I go to, and we have it at our surgery centers and other things. Again, with robotics, it allows us to not only know where the bone is in place, but then execute cuts that we've planned that are exactly how we want it. Now that also can be extrapolated to the hip, which for the hip, and again, just trying to make a few points. These are high-level generic terms, hopefully, but when we're doing, and I'm happy to talk more about it, but if we look at a hip right here, you can see that there's a hemispherical shape. Well, if we wanted to make sure that this hemisphere is absolutely perfect, we might, robotic arm could actually come in and allow us to create this shape exactly where we want it based off of a CAT scan. Whereas typically we are doing that potentially with just direct visualization and how it feels. And again, a lot of the time that has been very successful, but we have come to learn that as patients have more complex anatomy, maybe a fusion of their lumbar spine to their pelvis, the way that the body interacts with the hip, if the spine can't move, you're going to bend more at the hip. And likewise, if your hip can't move, you might bend more at the spine. But the point is, if someone has a stiff spine, they might be at a higher risk because they have to use that hip more to bend over to pick up something, they may be at a higher risk of dislocation. And you may want to put that cup in a slightly different position than if they didn't have that stiff spine. I'm again vastly oversimplifying this, and I'm happy to elaborate. But the point of that is, in those cases in particular, it's very important to know exactly where you're putting something like that hemispherical cup for the hip. And having tools that give you that precision based off of the actual patient's anatomy, not just what typically works for most people, which is what has been the rule of thumb, I think, for traditional joint replacement. For those particular cases, I do think there's a lot of value in the robotic technology and making sure that, and/or navigation technologies to know that you're not just putting something where you think you are, but you can actually have a way to measure it. I think that's one of the biggest things that these tools are giving us, is that they give us a way to have a ruler of sorts to what we're doing in the operating room. We have a measurement where typically with a knee replacement, we would say, well, when we move it, it's really loose on one side and tight on the other. Well, how much do we have to adjust that balance to make the knee feel nice and smooth and balanced? Well, typically it would just be how it felt. And, I think most surgeons, especially if you're doing hundreds of joint replacements, are very good at figuring out what feels right because they have a lot of experience doing that. I do think that robotics offers an opportunity to quantify what feels right. So not only do you know what is that feeling, but it's hard to maybe articulate that to the trainee you're talking to, or to or have someone else reproduce that. So I do think that that's sometimes beneficial for figuring out how you're going to balance, for example, that knee, or exactly a way to measure, did you actually restore things exactly as you planned in terms of alignment for that hip. The real exciting thing is, I think, the future of these technologies. There's growing interest in having implants that are smart. There are implants on the market that allow you to monitor sort of real-time information from the implant, and it how many steps and things like that. How active are you? Just like your smartphone or your smart watch, there's new growing technology for how to do that. And I think that that's beneficial for potentially in the future. That is still very much in the beginning stages, but I think helpful. There's also some growing interest in how do we utilize artificial reality and things like that into joint replacement. I think those still have some ways to go. I've definitely been following multiple companies and sort of their developments with different things on a routine basis, just trying to see what new technologies we can bring to the table. But I think what I would hope people can understand from this conversation, and again, I think a lot of it will come from our chats, are what are the options, and what type of things, how would it be beneficial? I think another thing that some of these technologies afford us is, as it gets more precise and more specific, and we can potentially be more able to utilize approaches to the knee that are more minimally invasive to, for example, on knees, a lot of the time I'm comfortable using a subvastus approach. Plenty of surgeons use that with routine technology and traditional techniques. But I do think by having a robotic arm where you've planned the cut, you can potentially utilize a smaller exposure, knowing that cut is going to precisely be where you planned it, versus where you otherwise might want to have a better view and make sure that the thing that you're looking at with your eyes, making sure it's just right, you're going to want to have a better exposure potentially to see that. Whereas as technology gets better, you should always check it, make sure that it's what it is planning, because you can always plan something poorly, and it could, so I don't want to say, I do not think any surgeon would rely on that hardware. But I do think it affords us some opportunity to maybe make these procedures less invasive. Instead of putting a rod down the center of the femur, we don't have to do that. I can tell you from experience that reduces thigh pain that patients report after surgery. When we look at data, I think the other thing to take away from this talk is that it's still pretty new, and a lot of the literature there is based on how much we can measure the difference. The difference between all comers with a more conventional approach for knees or hip replacements versus sorry, I looked at the questions, and I will get to those questions, but basically trying to figure out sorry if that distracted me, but sorry for the trying to figure out with the joint replacements. We'll basically want to make sure that the robotics allows us to get the best outcome possible. I do think patients or surgeons who are doing a regular technique, they're going to be able to have a great outcome with or without robotics. So I also think that that's something that, just because there is technology out there, you may not want to ask a surgeon to necessarily do a different approach or a different technique that they don't traditionally do, just because that may, frankly, there are learning curves to all of these technologies. And I think the exciting part about it for me is I think that there's, over the coming years, it's going to be increasingly more relevant and beneficial. I think that you can still have a good outcome. What I was starting to say, and sorry, I lost my train of thought for a second, was that the ways for measuring these outcomes is, it has to be so finite that sometimes these are not showing a difference between doing a conventional knee or robotics. I think that there's plenty of literature that does show benefits from robotics. I think a lot of it, and again, comes down to more anecdotal or kind of personal experience. I do know when we implemented it at my prior role, we kind of looked at how often we were refilling opioid meds. I didn't change how much we were prescribing. And the amount of refills definitely decreased when we switched to robotic procedures. And I think it was just because there was a little less manipulation of soft tissue and to actually get exposure and things like that. Because again, I felt more comfortable doing a slightly smaller incision. I think a lot of those things are surgeon specific, and you could do the same exposure for both a robotic procedure and a conventional approach and have a very similar in terms of amount of pain. So I think there's a lot of variability in terms of how you quantify how much benefit you can get from these robotic technologies. So the takeaway is that I think there's a lot of great opportunity for these, and I think it's very helpful for you to know about them. But at the same time, if you have a great relationship with a surgeon, you don't actually have to, and they don't use that technology, I wouldn't recommend necessarily changing anything. I think you want what people are comfortable using. I think the reason I think technology is critical is I think it does allow a little bit of precision when we do these surgeries, and especially for the future, I see that being that much more relevant for smaller incisions, more precise implants. As we refine our techniques, we can do that. There's also some benefits with knee replacements. There's different ways you can actually, there's different ways that you can fix the implant to the bone. There's a significantly higher rate of people utilizing what's called a press fit implant for total knees when they're utilizing robotics. A component of that, but there hasn't been an increase in loosening or anything like that where we worry about the implant not bonding to the bone. The idea being that when you have a robotic cut, it's going to be more steady. You have a robotic arm that can withstand significant amount of pressure, thousands of pounds, versus your hand, which may have a little more toggle, or the pins that are holding that cutting jig in a traditional knee. There may be a little more toggle and a little more slight, subtle, maybe not even to the eye, imprecisions with that cut. Whereas you can get rid of that when you're utilizing these technologies, which will allow for a more steady base where that implant can sit perfectly onto the implant and fit like a glove. And again, that's how you want it to be, especially if you're utilizing these press fit implants rather than what is a little more common, doing a cemented implant where we're holding the implants in place to the bone with cement. Those are a lot of the big things I want people to know. I would say the other technologies that are, because I focused a lot on robotics, there's different ways, different approaches to different for surgeries. And I think as we gain new technologies, again, it allows us to have slightly different exposure, maybe not needing to do x-ray and radiation when we're doing robotics for hips or things like that. A lot of the time hips are going to be done, and I still do a fair amount of hips with fluoroscopy, which is under direct x-ray view. One of the potential benefits of robotics is that it allows us to not need to radiate ourselves and the patient necessarily as much. So I think those are things to necessarily think about. And also some approaches and techniques may not be the right thing for every single person walking through the door. I think there's some limitations with some of the technology require a CAT scan. If you're getting a CAT scan, maybe that can be possibly a cost prohibitive thing if insurance didn't cover it, and maybe a reason to, there are some pros and cons to different technologies that are out there, where some systems need certain types of information and you'll get a different amount of information out of that. I think the biggest takeaway with technology and robotics is I think what we're aiming for is more precision. Before robotics, people were talking a lot more about, most implants for knees, for example, jump by about 2 millimeters. Now most of them have 1 millimeter increments, and I think that is because we're able to refine the difference on a much narrower scope. So I hope that I know that this is a topic that you could spend a whole weekend trying to extrapolate upon, and I think that's I'm trying to give the most brief overview I can. I bet I could extrapolate on pretty much any of those topics that I just mentioned significantly. So if there are questions, I think that's pretty soon we'll start answering some questions. But yeah.
Yes, thank you so much, Dr. Kraekel. So we will be answering questions submitted earlier and questions submitted live. Not every question will be able to be answered, but we will get through all of the ones that we are able to. So our first question is, What type of anesthesia and pain control are used?
So that's variable for every patient. I would say, like, for technology, some of the benefits, some of the newer technologies, since that's sort of what we're focusing on, is there's some newer type, and not that new, honestly, but over the last 5 to 10 years, systems where you can actually put the the medication is actually put into a vacuole of, or a little collection of fat soluble tissue, basically, so that it can dissipate at a slower rate, and that allows that medication to last longer. So some of the benefits are we can utilize medications that can potentially dissipate for a nerve block, and direct local injections in the knee in that nerve pain blockage, which is typically going to be something like an adductor nerve block, where you'll still have motor function, but it'll block some of the pain and sensation for up to 72 hours. So that's one of the big, I think, benefits. A lot of the anesthesia is going to be patient dependent, and the anesthesiologist, but a lot of them, we are doing significant amount of spinal anesthetic. The benefit of that is patients typically wake up, bright-eyed and ready to work with physical therapy, where some of the traditional gas anesthetics, where you're intubated, tend to have a little bit more of a hangover effect.
Thank you. Is there an age limit for the types of replacements you're talking about?
There's no age limit. There's no age limit for hip or knee replacement. There's definitely no age limit for robotics either. I think the benefit of the way to think about it is, as we age, we tend to accrue some medical problems, and so it becomes a much more. It's definitely a pros and cons conversation that we have with every patient. But as patients age, the risks potentially go up, and so we do focus a lot of time and discussion about, how bad is it. But there's plenty of people that I've operated on who are, in their late 80s and 90s. I wouldn't say it, but we try to, as patients age, we definitely try to utilize every single conservative measure first, but sometimes that's what's necessary. And then some people, age. I've had patients in their 80s be the second case of the day, and they recovered and went home before the first case that was, in their 50s. And it's really not. Age is not always the best predictor of how quickly someone's going to bounce back from a surgery. So, I think there is no age limit is the answer.
Thank you. How long is the actual time in surgery for these robotic hip and knee replacements?
So typically it really is not that different from a traditional knee. There is a little bit, some of the benefits of the robotics that I didn't get into is, like, when we do a traditional knee, we have multiple extra trays that are opened of equipment for performing the surgery manually. Once there are different sets of equipment, but it's actually fewer when we do a robotic knee. And so there's actually a lot less setup and a lot less interventional steps. You sort of trade one for the other. And so I would say that the goal is generally going to be more of a time neutral situation, where it's not necessarily adding time. They don't necessarily add time. I will say, for surgeons early on, and even when I started with it, I would double check every single aspect of the surgery. So it does add time initially. If someone's, but I would say at this point, for me, it's a relatively time neutral procedure, whether I'm doing robotics or not. Both hip and knee, it's really just a matter of balance, making sure that you have the setup that you want for that procedure. It can add a little bit of time in terms of that setup, but you save it in terms of the implant that you planned is the one that's being put in. It's trialed. Based off of the implant planning, exactly which implant's going to fit the bone perfectly versus checking it intraoperatively. And you do still check it, but it's very rare. That does happen, but it's very rare that you change. I mean, there are times that I will maybe change the implant size down one size or something, but you're usually very precisely able to predict things ahead of time with your planning stages as well.
Thank you. So for someone under 50, cord decompression versus hip replacement, and what is the life of the implant?
Yeah, it's a great question. So I have that conversation frequently with patients. I think if the real answer to that question is it depends if the head of the femoral head has collapsed or not, and how extensive the AVN is, the avascular necrosis. Just for anyone else listening, avascular necrosis is when we all have a sort of humans have a unique anatomy to the hip, where the ball of the hip can have limited blood supply because it takes a U-turn, and so some people are prone to that blood supply being diminished for a variety of risk factors. When that happens, if we can restore blood flow to that hip, it can heal and actually get a lot better. That's what that cord decompression is. Some of the advanced technologies in that I typically do, I actually will usually harvest some bone marrow from the pelvis when we do that surgery and inject it into the same spot that we do the cord decompression to try and instigate healing and improve the chances of creating new blood flow to that area, because that's typically the problem. So we drill several holes into the area, but then also putting some bone marrow aspirate to try and or stem cells effectively to try and get that area to heal. I've actually had quite a bit of success doing that, but I think in a younger person, I would definitely steer them towards the cord decompression if it's a appropriate procedure. Not everyone is a good candidate for that, so really to answer that question, you would need to see imaging. But if it is a good option, I would usually try that first, because even if it gives you 10 years, you're getting a hip replacement 10 years later. And most surgeries, we know most joint replacements, and this is a generalization, but hip and knee replacements, typically you can expect to have the same implant for about 20 years, 95% of the time. After 20 years, the lifespan of those implants begins diminishing due to need for revision. So if someone's 50, there's a high likelihood they're going to need a revision in their lifetime, and if you could push it back 10 years, it might be less likely just based on human longevity.
Thank you. Are robotic for revision surgeries?
So currently it's on and off label. So yes, it is used off label in some regards. And then typically, meaning some of the systems out there are not necessarily approved for that utilization yet, but they're in the process. And then there are actively, I know most of them are being approved for, or at least the two main ones that I have extensive experience with, both of which are getting approved for revisions, and they're actively working on that. So it is very useful. I think it can be utilized in those settings. It's a matter of also the comfort level with the technology. I would say someone who's new to the technology probably wouldn't use it in those settings, just because they would have to have the comfort level of the limitations of the technology as well. But it is again sort of acceptable to use, but probably not. It would be off label for what the companies would market it for as of today. But in the coming year or two, that's going to change.
Thank you. What is the average recovery time after a hip or knee replacement?
Sure. So everyone's a little different, but I tell most patients the knee is a little harder than the hip. Most people, when I do a surgery, they get up, walk with physical therapy, they go 100 feet, they walk and go to the bathroom, they do steps, and about 90% of the time they're able to go home the same day. So the initial stages of recovery, it's going to be a little bit kind of quantifying what that recovery is. You're able to walk that day. Are you able to walk well? Probably not. You're using a walker, and you're going to be in pain and tired. Typically, the first 2 weeks is tough. I do tell people that to be mentally ready, that don't plan to necessarily do very much in terms of work, and have extra help during that first week. Definitely the first week, ideally the first 2 weeks, to just help you keep track of medications, help you to get up and, if you need a glass of water, you don't necessarily have to get up every time. They can help you. Then after that, a lot of people with a desk job who are able to work from home or remotely are usually doing work within that first week or two. I would say anyone with a heavy laborious job, I'm often recommending that they hold off for about 6 weeks. Some people are back sooner, but it can take up to 6 weeks to really feel better than before we started. I tell most, that's what I tell patients, and I would say, generally 95% of the time, if I see you at the second visit, which is usually about 6 to 7 weeks after surgery. And people say I'm still achy a little bit, but I'm markedly better than before I started. And so I think that's an all relative thing too, because the more pain you're in going into the surgery, you might have lost some of your strength, and you might be a little further behind in terms of just trying to get back to a normal life and ability to walk longer distances. So sometimes there's a little more of an uphill battle if someone's been had a severe arthritis for a long time and they've sort of, not, I don't want to say neglected, but sort of lost activity. That might be a harder recovery than someone who has bone-on-bone arthritis, but we've sort of acted on it a little faster. But that's the general rule of thumb, I would say, for recovery. Most people, I tell them they should wait about 3 months before you book any big, travel where you don't want to be thinking about the joint. And that's a pretty safe, very safe number, I would say.
Thank you so much. That is all the time that we have for today. Dr. Kraekel, would you like to close?
Sure. So I think there's a lot of really good questions, and I'm always hopeful to answer more. I think what I can try to do is keep track of some of these questions and answer them. Trying to make more videos for the website so you guys can see them. I hope this gives you a flavor of sort of some of the technology out there, things that you can expect, things that I'd be happy to talk to you about, in terms of how we could help you, whether or not technology would be a good option for you. I think no matter where you are, I think it's just valuable to know, because it's sort of amorphous, and I think a lot of people have questions about what these technologies are. I think the key is, frankly, you want a surgeon to do what they're comfortable with, and they're going to do a good job. I think the promising thing is these technologies, I think, as we develop them, it's opening so many doors for how we can refine these surgeries and things like that. Thank you.